We've all had them. Headaches can be debilitating, and they happen when any of the pain-sensitive structures in the head and neck are stimulated. These include the meninges, blood vessels, nerves, and muscles. Headaches can be classified into primary and secondary headaches. Primary headaches include tension, migraine, and cluster headaches, whereas secondary headaches are those that are due to another underlying disorder. When an individual has a headache, especially if it feels different from their usual headaches, it's important to think through causes of secondary headaches to avoid missing something important or life-threatening. The mnemonic SNOOP, without the D-O-double-G, summarizes some of the red flags. S is for systemic symptoms like fever or weight loss. N is for neurological symptoms like weakness, sensory deficits, or vision loss. The first O is for a new or sudden onset headache. The second O is for other associated conditions like trauma. The P stands for progression or pattern, like a headache that's worsening in severity or frequency. Any of these findings warrant further investigation like brain imaging with a CT scan or MRI, and in some cases a lumbar puncture. Some clinical features might point toward a specific diagnosis, some of which might be life-threatening. For example, if the headache develops suddenly and feels like a 10 out of 10 in terms of pain right at the onset, or if it's called the worst headache of my life, then it might be a subarachnoid hemorrhage, and it's typically caused by rupture of an intracranial aneurysm. Now, if someone has a sudden headache after a trauma, and it radiates down one side of the neck and is associated with Horner syndrome, then it could be due to a carotid or vertebral artery dissection. This is also associated with pulsatile tinnitus, which is a pulsating ringing sensation in the ears. If left untreated, the dissection could extend into the intracranial vessels, leading to a stroke. Now, it's not just the arteries hogging the show. The cerebral veins might become blocked in a condition called cerebral venous sinus thrombosis. This presents with exertional headache, focal neurological deficit, and signs of increased intracranial pressure like papilledema. This happens more commonly in individuals with hypercoagulable disorders, or women who are in a hyperestrogenic state, like pregnancy or use combined oral contraceptives. Now, an acute headache that's associated with fever, photophobia, neck stiffness, or altered mental status should worry you about a central nervous system infection, like meningitis or encephalitis. Also, a brain abscess can present with headache and focal neurological deficit with or without fever, and there might be signs of increased intracranial pressure like nausea, vomiting, and papilledema. Acute angle closure glaucoma might also present with an acute headache that's more intense in the periorbital region, and is classically associated with a red eye, a fixed mid-dilated pupil, and visual impairment. If a person recently had a head trauma, epidural or subdural hematomas should also be considered. Brain tumors can also present with a chronic, dull headache that's usually worse in the morning and when lying down, improves when sitting up, and is often associated with symptoms of increased intracranial pressure, like nausea, vomiting, or papilledema. Other symptoms of brain tumors include seizures, focal neurological deficit, and psychiatric symptoms, like a change in personality. Pituitary tumors can also cause a headache along with the loss of peripheral visual fields due to compression of the optic chiasm, which is known as bitemporal hemianopia. Additionally, since prolactinomas are the most common pituitary tumors, signs of hyperprolactinemia like galactorrhea, decreased libido, amenorrhea in women, or erectile dysfunction in men might also be present. Speaking of the pituitary gland, another dangerous cause of headache is pituitary apoplexy, which is bleeding in the pituitary gland. This happens when a pituitary tumor outgrows its blood supply and causes a sudden onset headache associated with visual field loss. Also, in pregnancy, the pituitary gradually enlarges to meet the demands of breastfeeding after delivery. If women suffer from severe postpartum hemorrhage, ischemia to the pituitary can cause pituitary infarction, a condition called Sheehan syndrome. Alright, now temporal or giant cell arteritis is a vasculitis that primarily affects the extracranial carotid circulation, and it usually happens in individuals over age 50. The headache is a superficial, pounding headache along the temple of the head. In fact, the scalp might be so tender that even brushing the hair can be difficult. Other symptoms include fever, weight loss, and jaw claudication. Because giant cell arteritis involves the carotid circulation, a worrisome complication is extension of the vasculitis to involve the first branch of the internal carotid artery, the ophthalmic artery. This could potentially cause irreversible blindness in one or both eyes. Finally, a condition called idiopathic intracranial hypertension, or pseudotumor cerebri, can also cause a headache. This disorder is characterized by an increase in intracranial pressure for an unknown reason. Individuals tend to be young, obese women, and other risk factors include oral contraceptive use, as well as tetracycline and vitamin A toxicity. In addition to headache, individuals might also complain of visual disturbances like diplopia and a sixth cranial nerve palsy. On fundoscopic examination, there's usually bilateral papilledema, and the CT and MRI of the brain are usually normal. A lumbar puncture is diagnostic and reveals an opening pressure greater than 250 milliliters of water, with a normal cerebrospinal fluid analysis. Treatment consists of weight loss along with the carbonic anhydrase inhibitor acetazolamide, which helps lower the intracranial pressure. If papilledema is extensive and vision-threatening, then a procedure called optic nerve sheath fenestration surgery is done emergently. Sinusitis can also present with headache, and a characteristic feature is tenderness of the affected sinus on palpation. Finally, caffeine withdrawal can cause a mild headache approximately 12 to 24 hours after the last cup of coffee. Alright, once the secondary headaches have been excluded, primary headache disorders should be considered. Tension headaches are the most common primary headache disorder. It's a slowly progressive, bilateral, tight, band-like headache with no other associated symptoms. Typically, it lasts from 30 minutes to up to a week, and is usually triggered by stress and dehydration. Tension headaches are commonly treated with analgesics like acetaminophen and NSAIDs. A migraine headache is another primary headache, and it's more common in women. Migraine attacks usually have triggers, like specific foods, weather, bright lights, loud noises, physical exertion, or lack of sleep. Migraine headaches usually last between 4 to 72 hours, and it's usually severe, unilateral, pulsating, or throbbing pain that's aggravated by movement. Additionally, individuals can have nausea or vomiting. Often, individuals isolate themselves in a dark room to avoid light, or photophobia, as well as sound, or phonophobia. Some migraines can cause an aura before or during the headache, which consists of visual symptoms like seeing bright lights, zigzag lines or hallucinations, or other neurological symptoms like tinnitus, aphasia, or confusion. Sometimes the aura can present as a temporary paralysis of one side of the body, in which case the attack would be called a hemiplegic migraine, and can be confused with a stroke. Migraine treatment is categorized into abortive therapies, which are used to treat an acute migraine attack, and prophylactic therapies, which are used to prevent another attack from happening. Acetaminophen and NSAIDs might be used as abortive therapy for mild migraine attacks. However, they're usually ineffective at treating moderate to severe attacks. That's why medications called triptans are usually first line for the abortive treatment of most migraine attacks. An alternative to triptans are ergotamines, like dihydroergotamine. Both classes of medications act as serotonin agonists, and can be given orally, nasally, or parenterally. Importantly, triptans are contraindicated in individuals with coronary artery disease or cerebrovascular disease, and in pregnancy. Finally, dopamine antagonists like metoclopramide and prochlorperazine have also been shown to be effective abortive therapies, especially when the migraine is associated with nausea or vomiting. This is because dopamine antagonists also act as antiemetics. More often than not, a combination of different medication classes might be needed to effectively treat an acute migraine attack. For prophylaxis of migraines, there are various classes of medications that can be used. Anti-epileptics like topiramate, gabapentin, and valproic acid, beta blockers like propranolol, and tricyclic antidepressants like amitriptyline are all options. Finally, a special consideration in women with migraine with aura is that estrogen-containing contraceptives are absolutely contraindicated, because they have shown to increase the risk of stroke in this population. Cluster headaches are the rarest form of primary headache, but are the most common amongst a group called trigeminal autonomic cephalgias, and they usually happen in men. The other types of trigeminal autonomic cephalgias are incredibly rare. Cluster headache is classically described as an excruciating, stabbing pain located unilaterally behind the eye. Now, the reason they're called cluster headaches is because they usually happen every day for about 8 to 10 weeks per year, and not the rest of the year. Interestingly, these headaches happen at almost the same time every day, and last anywhere between 15 minutes to 3 hours. Cluster headaches have been linked with cigarettes and alcohol. Oftentimes, individuals with cluster headaches pace around, because there's nothing that really provides comfort. Cluster headaches are also associated with autonomic symptoms on the affected side, like ptosis, meiosis, tearing, and nasal congestion. Alright, now similar to migraines, the treatment of cluster headaches is both abortive and prophylactic. Oxygen inhalation is the first option to treat an acute cluster attack. The individual should be placed on a non-rebreather mask and given 100% oxygen at a rate of 10 to 12 liters per minute. Additionally, triptans can also be used as an alternative abortive treatment option. As for the prevention of cluster headaches, the calcium channel blocker verapamil is the medication of choice. Other prophylactic options include corticosteroids, topiramate, and lithium. Now, you could imagine that individuals with primary headache disorders might frequently use analgesic medications to treat acute attacks. But this can paradoxically cause a condition called medication overuse headache, creating a vicious cycle. Therefore, the best approach for these individuals is to reduce the dose or stop the medications, which dramatically improves their headache. This is an incredibly common issue, and it isn't possible to treat an underlying primary headache disorder effectively until the medication overuse headache has been addressed, which can be incredibly challenging. Finally, there's trigeminal neuralgia, also fancily called tic douloureux. Trigeminal neuralgia is a neuropathic pain disorder that's thought to be due to compression of the trigeminal nerve in the brainstem by the superior cerebellar artery. Individuals classically describe sudden, excruciating, sharp, lightning-like unilateral facial pain in the V2 and V3 trigeminal nerve branch distribution. These attacks can be spontaneous, or they can be triggered by irritating activities like chewing, shaving, brushing the teeth, talking on the phone, or even simply smiling. The pain can be very short-lasting, causing the individual to frequently wince or grimace in response. Therefore, it might actually look like the individual has a tic, hence the name tic douloureux. Importantly, one of the core features of trigeminal neuralgia is that the neurological examination will be completely normal, despite the localized pain episodes. Now, the symptoms of trigeminal neuralgia, in particular if it occurs bilaterally, can be due to multiple sclerosis or a brainstem tumor, so it's important to consider these diseases. Alright, now the medication of choice to treat trigeminal neuralgia is carbamazepine. Alternative options include phenytoin, gabapentin, and baclofen. If medical therapy fails, surgery might be needed to cut the nerve with heat, a procedure called thermal rhizotomy. Or since it might be caused by the superior cerebellar artery compressing the trigeminal nerve, a procedure called microvascular decompression can be performed. Alright, as a quick recap. When evaluating an individual presenting with a headache, it's crucial to exclude secondary causes of headache first, as some of them can be life-threatening. Primary headaches include tension, migraine, and cluster headaches. Tension headaches are described as a tight band wrapping around the head, and last between 30 minutes to 7 days. For tension headaches, abortive treatment includes acetaminophen or non-steroidal anti-inflammatory drugs, or NSAIDs. Migraine headaches are described as a unilateral, throbbing pain, and cluster headaches are described as a retroorbital stabbing pain. Migraine headaches are often associated with an aura, photophobia, phonophobia, nausea, or vomiting, and last between 4 to 72 hours. For migraines, abortive therapy options include acetaminophen or NSAIDs for mild migraine attacks, and serotonin agonists like triptans and ergotamine, or dopamine antagonists like metoclopramide for more severe attacks. Prophylactic options for migraines include anti-epileptics like valproate, beta blockers like propranolol, or tricyclic antidepressants like amitriptyline. Cluster headaches are associated with autonomic symptoms like ptosis, meiosis, tearing, or rhinorrhea, and are short-lasting, between 15 minutes to 3 hours. Abortive therapy is oxygen inhalation, while verapamil is the medication of choice for prophylaxis. Finally, it's important to consider medication overuse headache and trigeminal neuralgia as part of the differential diagnoses.